And so without further ado, I just want to warmly welcome Dr. Donaldson up to the stage. She's going to tell you a little bit about her journey through providing gender-affirming care as a family doc. You can go there. Yeah.
Hi, everyone. My name is Suze Donaldson, as she said, and I'm a family doctor in Surrey and Surrey Delta. We did a survey with our group last year, and 23% of people responded that they were aware of how to provide gender-affirming care. 74% said they had no training for gender-affirming care. That would be like me. And I got involved because I had some patients that came to my office and asked me if I could help them. And I didn't have any training, and I just said, well, you know, we can work through this together. And that's how I got involved. I wanted to talk about a couple of things that I was going to address tonight. A few terms, and a lot of you may know terms, so I apologize. Sometimes it might be basic stuff for people. And also things that I learned, things that I was incorrect with. And then I wanted to share with some family practice scenarios that I've come across in my office. So I continue to learn about transgender care. Last time in the fall when we had our talk, we got a bag of resources. So I opened it up a while later, and there was a flag in it that was purple, yellow, and white. I had no idea what it meant. And I knew that a pink, white, and blue flag was a trans flag, but I didn't know what the other one was, and I had to Google it to find out that it meant represented non-binary people. So a lot of patients, I sometimes, and if you're seeing transgender patients, a lot of times I might use the wrong word or learn words that people use more frequently. I initially thought I was calling it a mastectomy versus a lot of people will say top surgery, which is removal of breast tissue. I also thought I was referring to breast implants versus chest construction. And patients would come in, they may come in and talk about T, and they're referring to testosterone. And one of the things that's important, I think, is that one of my main points for tonight is that patients are often scared to come and talk to you. And even though you're their doctor, sometimes they're buying things off the internet because they're scared to talk to you and approach you about transgender or gender-affirming care. Sometimes people will refer to dead naming, and that's when in the office or anywhere, that may be referring to somebody by their name that they were born with versus they have a name that they have chosen that is what they want. And so sometimes staff, it's in the EMR what their birth name is, and they don't use that name anymore. So that's what that means. And in the toolkit that we got, so some suggestions that I would say is don't assume because someone identifies as transgender that they want hormones or medical interventions. So a lot of times what they're interested in can change and is quite fluid. So another thing that I was thinking about, when you read about transgender care, they talk about when you meet a patient to ask them what pronouns they prefer. So in my practice is closed. I have been a doctor in Surrey for a lot of years, and I don't have really new patients, except if my patients are having babies. So I'm not meeting my patients for the first time. I'm seeing them for years and years. I might have seen them as a child, and now I have patients that are having babies that I met when they were kids. So that, I suspect, is probably similar for a lot of other people that are here. So I think it's really important to talk about with patients, what are their goals of care and what are they interested in right now. Also, that is, as I said, it may change. And are they interested in socially transitioning? Some of the things that I assumed, which are incorrect. Initially, I thought if you're a transgender male, this is my own ignorance, I thought, well, then it must mean they want removal of breast tissue or top surgery. They probably want their uterus out and they want a penis constructed, which is wrong. That a lot of people, it certainly can vary, and that's the thing with any family practice, is your issues that you're seeing are varied. I also thought that if you were trans male, I assumed wrongly that the person might want their penis removed, that they would want breast construction, and they would want surgery to have a vagina, which is very frequently not the case. In my own practice, I certainly have more trans males than trans females. And I actually only have one trans female that did have vaginoplasty to create a vagina. The other thing, I was just going to talk about some scenarios that I've come across that you might have some similar experiences. So recently, I went into the room, and the patient that is now in their late 20s, was sweating buckets when I went in. And I said, you look really stressed. And the patient said, do you know what non-binary means? And then I said, yes, I do. And then I felt like an idiot that I didn't clue in that this person was non-binary. This patient was sexually active, or is sexually active, with a male partner. And I've seen this patient since the patient was probably 10. The male partner had encouraged the patient to talk to me. So again, for goals of care, sometimes that, and Dr. Kissok's going to talk more about this, I think, or the speakers. But for this patient, the goal was stopping periods, not getting pregnant, and then was very, very stressed about their mother, who's also my patient, because I see the whole family. And I said, what stresses you about your mom? And so the patient said, what if I don't ever want to be pregnant? She's going to freak out. So this is another thing with family practice is, I think if you have a full family practice, you have to keep asking questions because you'll see so many different people in the family. I recently had a grandma who came in, and I see an adult grandchild who's transitioning. And I said, I was the one that brought it up. And she said, well, when we lived together, we talked all night. We would stay up all night and talk about everything. And now I don't know what to say. I don't know what to talk about. I don't even know subjects to bring up. And I said, it's the same person this is the same person. Even if they're transitioning, you can still stay up all night and talk about things that you used to. And she's totally stresses about this. And so she'll come in for something else and I'll say, oh, how's it going? You know, have you guys got together lately. So just to continue to ask questions. And again, I'm generalizing, and there's certainly different scenarios, but generally I find that siblings or teen patients, often transgender care or the topic doesn't really faze them. I've asked my own kids, I asked them, oh, how's so-and-so, how's his family? And they said, oh, he's good, his mom's good. His sister's his brother now. Yeah, but they're fine. And then they went on to the next thing to talk about, because it really didn't faze them at all. That's something that I've found with siblings, but it's okay. I mean, I have run by and said, so how do you feel about your brother or sister, and about them transitioning? Because a lot of times, I think as their family doctor, you're the main person sometimes that they can talk to. So even with parents, they might have a family member or someone who's close to them who is transgender. They may be very scared to talk about it. Often they may feel guilty and overwhelmed, and they don't feel like there's anyone really that they can talk to. Sometimes even their partner, if they have a partner. Because I have patients that parents or their kids who have come in, and the person who's transitioning says, I'm not telling my other parent, I only want my mom or my dad to know. And so anybody in the family may be really nervous to talk about other family, to other family or with other family about this and bringing it up. They may be really stressed about talking to friends as well. They don't know how to bring it up or how to approach it. Or sometimes even others in their community. And culturally, it can be a very significant issue for people to bring it up, that this as something to talk to people about. I find as well that a lot of patients, my patients that I see that are transgender, sometimes have other your run-of-the-mill family practice problems. I have one teenager with terrible, terrible anxiety who thought that he had a breast lump. He was just shaking for me to do an exam. And I think sometimes if you can work around stuff. So I was actually, for this person, I was able to do an exam and the person was fine, but to do it with the person's shirt on, because he could not have me examine him with his shirt off. It was too stressful. The same person came in with palpitations another time. So my plan was to do lab and also a Holter. But then I thought, how am I going to do a Holter in somebody who binds? Because a lot of people will bind their chest binding. So sometimes I think it's a good idea to bring, say, I don't know how we're going to do this. So we figured out a plan for that for him. His mom is really supportive, and we decided, why doesn't he just do it on a weekend when he's home and he's in a safe environment? He was at home and could do it then. And that worked great. I have another patient, trans male, who presented with genital discharge, and I was away, and he saw my office partner who did a genital swab. Then it came back from Life Labs that said, why are you doing a bacteriovaginosis swab on a male? So sometimes you have to work around stuff like that. My office partner had to contact the lab and explain it. Again, I find patients, he was really very grateful. And you have to sometimes stick up for your patients because sometimes other people aren't sticking up for them. I also have a trans female who came in post-op. She had had a vaginoplasty. So as the people here talking tonight, Dr. Kissok and Dr. Hursh are the big cheeses in this. I'm not. And so I was supposed to do a vaginal check and to use silver nitrate on granulation tissue. And I said, so I was honest with the patient. I said, I've actually never seen a vaginoplasty, so I'm game to try to help you, but this is new to me. So, and it worked out great, and the patient came back for a couple follow-ups. Another issue that came up with a patient who was initially taking testosterone, then stopped it, then became sexually active with a male partner. And I was thinking, but if you're sexually active and you're not taking hormones, you might get pregnant. And so the patient said, yeah, I do not want to get pregnant, but I'm really bad about stuff. I haven't done anything to protect myself. And so you've got to keep asking questions about that, about keep probing is kind of my key point. I have another guy that I talked to today, and we joke a lot, and he's trans male. He actually flies down to see me in Surrey because he can't, he's not comfortable in his community to even look for a doctor there. And we joke a lot. And a coworker approached him and said, apparently there's a tranny on our crew. He is a construction worker. And so he said, you wouldn't know a tranny if they were standing in front of you. And the guy said, yeah, I would, actually. So my patient's response was to lift up his shirt and show his surgical chest scars. And the coworker said, no fucking way, and had no clue that the patient was trans. And so he tells me lots of stories like that. So basically my key points as a family doctor is that you want patients to feel safe and that they can talk to you. I'm conscious that I try to use the right pronouns. Sometimes I mess up, but I do ask patients, or I apologize if I make an error, and I call it right away. So in summary, the goals of care, as I said, are to be aware that things may change, and to reassure patients that it's okay, that nothing is set in stone, I always say to patients, and it's okay if what is right for you today is not, in 6 months it may change. So when April asked me to talk tonight, I thought I really don't know what I would have to offer to a group of family doctors and nurse practitioners when we have people like Dr. Hursh and Dr. Kissok. But family practice really is a very good place to start transgender care. I was thinking last night about why I became a family doctor. I really wanted to look after whole families. I have newborns, and I have a couple patients that are turning 100 this year, and I have 4 generations of families. So I wanted a variety of problems and issues to deal with patients. So trans care really is a way to broaden your scope as a family physician and to help people because sometimes you are the main person for them to talk to. And I was going to say as well, if you're nervous about having trans patients, think about them. So if you're accepting a patient and they're transgender as a new family doctor, you're meeting them. You kind of know the scene, you know you're going to ask them all this history, but they have no idea what you're like. And are you going to be open? Are you going to be okay with what they're talking to you about? Or, as I said initially, if you're seeing them or their family for a lengthy period of time, think about how intimidating and scared it is for them to bring up trans care with you, like that person that I just talked to. Because if you've seen their grandmother, their parents, their siblings, and you're that person for the whole family, they have no idea how you're going to react and are you going to be okay. And it's really hard, I think, for a lot of patients to bring this up, and I've had that experience as well, that they're really scared. What if it's not okay, and how are they going to react? And so I think it is a very worthwhile family practice issue. And that's it.
Thank you all for coming here today. It is so lovely to see the faces of a lot of the names I've been seeing written down for so many years. Oops, oh no. Oh, my slides aren't working properly. That's okay. So as far as our objectives today, in the same way that a lot of the patients of yours that I see for diabetes management who realize they're not coming to the principal's office every time they come see me after their A1C, I hope that you all are able to realize today that you're actually doing a lot of this care already. You're prescribing a lot of these medications, you're writing these regimens, you're monitoring them in the same way. It just may be that the gender marker in the EMR is a little bit different, or the patient's preferred pronouns are different than your traditional way of prescribing these medications. So what we're going to do today is we'll do a review over the feminizing and masculinizing therapy regimens. So we'll talk about the hormones. We'll talk about the different treatment options, the preferred treatments, the titration of them. We'll talk about the clinical changes, how we monitor them, when you expect to see them, when you may see patients coming in with adverse effects and what to look for. We'll also talk about the lab monitoring regimens, how often to check, what to look for. And then as well, we'll touch base quickly on some of the things that are in your toolkit, which include pharmacare coverage for medications, which ones need special authority, which ones are regular benefit. And then as well, I made a little flowchart navigating the referral process because I find very often that's the biggest black box of patients going ahead with gender-affirming care is, this patient has come to me and they're interested in transition. What do I do next? And then at the end of this, we'll troubleshoot some cases. If we're running out of time, we can always save them towards the Q&A portion. I tried to add in things I've been called about on call, things that I have encountered in my own practice. And then the Endocrine Society very kindly at this year's meeting or past year's meeting in June actually had a clinical conundrums in gender-affirming care presentation. So I took some of their pearls to share with you guys today. So, as Dr. Donaldson had mentioned, gender-affirming care must be individualized according to the patient's goals. This data is from the 2015 US study and then also a Canadian study that was done in Toronto, more looking at mental health aspects, but they actually looked at the degrees of transition that a lot of patients go through. So, like Dr. Donaldson had mentioned, not everybody transitions. I actually give a version of this talk. The initial talk was given at Surrey Memorial Grand Rounds back in June of 2019, so it's very much evolved over the last 5 or so years. But very often I give this talk to the rotating residents through our Surrey Endocrinology division. And for the last 5 years that I've been giving this talk on the Fridays while they rotate, I always ask, when I say gender-affirming care, when I say trans care, what do you think? And I find that over the last couple of years, there actually has been a shift in the way that these trainees are approaching gender-affirming care. So whereas 4 years ago, everybody would talk about how do I eloquently say gender reconstruction surgery, to now people are talking about binders and about hormone therapy and menstrual suppression. So hopefully we are able to understand through today, like some of these trainees are finally starting to get to, that there is a wide variety when it comes to gender-affirming care. And as you see here, most people do not fully medically transition, if at all. The majority of patients, about 3/4 of them, will do social transition. And in the family practice or general practitioner role, this can involve things like helping patients with the name change process, with gender marker changes, with education about how to do safer chest binding or safer genital tucking, which in the primary physician's toolkit on Transcare BC on their website, they actually have 2 really great links that I very often email to patients that give some tips and tricks on both tucking and on binding. And you can find those on the Transcare BC website, and they're also in the Toolkit PDF. And then we have patients that will go ahead with medical therapy. So this is the hormone therapy. This will be the bulk of what myself and Brandon will be talking about today. But as you see here, about half patients decide to pursue medical therapy, and there is a wide variety of the type of medical therapy that they want to pursue and the degree to which they want to pursue it. And then surgery, as you see here, it's only about 1/4 of respondents that are going ahead with surgical management. This may include chest surgery, may include breast surgery, gynectomy, genital reconstruction. Like Dr. Donaldson said, I also only have 1 patient in my practice that has had vaginal reconstruction surgery, and one that I've just recently referred for. And I probably had 5 or 6 patients just in yesterday's clinic alone. So this is not as common as is widely expressed in the media. So we'll go ahead and talk about the hormone therapy today. I chose to speak about the feminizing regimen first. This one is definitely more in-depth. It does involve 2 types of medications versus the masculinizing regimen. We'll talk about why. So without further ado, estrogen-based therapy. So the one thing I would like you all to take away from this from a medical standpoint is testosterone drives the phenotype. That is the main takeaway. So when we're talking about estrogen-based therapy, we need to suppress that testosterone so that we are able to get the effect of that estrogen providing those feminizing characteristics. Suppression of testosterone can be done through suppression of the GnRH, which Dr. Hursh will talk about. Cyproterone also affects LH secretion, which decreases testosterone. Our main go-to is spirulactone, and you can see that this interferes with binding of testosterone, with the conversion to DHT, and then also with the production of testosterone. And then once we've lowered that testosterone, then we can introduce the estrogen as a principal agent to induce those female characteristics, and that works through directly stimulating the estrogen receptors in those target tissues. You'll see how this is different when it comes to masculinizing therapy. So very, very detailed table. This is a more updated version of the one that's in your toolkit. The one in your toolkit is from the Transcare BC guidelines, which were last published in 2015. There were some changes to the guidelines in therapy 2 summers ago now, so I've included them to include some of the newer therapies. As far as estrogen and choice of estrogen, so when we're thinking about oral estrogen, you'll see is the 17-beta estradiol estrase, which a lot of you are likely prescribing for HRT in menopausal women. The ethinyl estradiol, which is the one that is more commonly in the combined oral contraceptive pills, is not recommended for gender-affirming care, and that is also more likely to cause VTE. We'll talk about that in one of our cases here. So that one is absolutely not recommended. Estrase is our choice when it comes to oral estrogen. Topical estrogen is also an option. So we have the estradiol patches or estrogen-containing patches and estroderm, which is the gel. Now, when we look at these forms of therapy, you can also see that there's an IM sub-Q version, and that's estrogen valerate. So estrogen valerate is the new addition from summer of 2023 to the regimen. There's not as much data out about estrogen valerate. Right now in BC, it's only available from compounding pharmacies. So McDonald's Pharmacy on Broadway in downtown Vancouver will actually prepare it for patients and mail it directly to their house, so they're able to get the access for it. Unfortunately, though, it also means that as a compounded medication is not eligible for pharmacare special authority. So cost can become an issue. When it comes to the patches, or the topical estrogen, you can apply for special authority if the patients are over 40 years old and they have risk factors. I was actually able to secure it for a patient in her 50s who was starting to transition because she had a significant family history of dyslipidemia in both her parents. Her LDL was not in a familial hypercholesterolemia level, but it was, in the high threes. So they actually allowed us to have special authority coverage lifelong, which is different than topical testosterone. We'll touch base on that for this patient. The estrase tablets, they're a lot cheaper. They're easy to prescribe, and they can be divided BID at the higher doses. When you look at the dosing here, so pre-orchiectomy, if patients do go on to have gonadectomy, the dosing regimen starts at 50 micrograms twice a week of the patch or 1 to 2 milligrams of estrase per day. How many of you are already prescribing that regimen? Anybody? For menopause, maybe not for testosterone purposes. So very often we will start with these lower doses of estrogen replacement, and is the exact same dosing that you would start in patients started on HRT. The maintenance doses do vary, and they're quite higher than we're typically used to. So patches can go up to 400 micrograms twice a week. The patches only come in 200, so it ends up being a lot of patches and is very, very costly. I have one patient that tried it for a long time, and then we switched over to the sub-Q estrogen. And then the maintenance doses as far as the oral estrogen. So the 2015 guidelines actually say up to 6 milligrams. The more updated versions say 4 to 8. I would say majority of patients end up somewhere between the 4 to 6 mark. The majority of patients are probably taking it twice a day, typically a 1 milligram and a 2 milligram dose. The oral estrase, you can actually give sublingually as well. So when we talk about sublingual estrogen, or inevitably if you're talking to patients about gender-affirming care, they will bring up sublingual estrogen. The beautiful thing about this population is the patients are very well read and well researched because they don't have anywhere else to go. So I actually scour those Reddit boards like I do for the hypogonadal guys I see for testosterone. And there is a lot of, what did my patient call it? Bathtub hormone regimens that are recommended. But a lot of these patients will bring up, what about sublingual estrogen? So sublingual estrogen is literally estrase that you put under the tongue. So it's the same tablets as they're taking PO. They're just allowing it to dissolve under their tongue rather than swallowing it whole. What happens in this is you get a very large upswing of the estrogen, sometimes into levels of 1,800, 1,600 levels, and then they come down. The times that patients will bring this up or want to speak with you about it is if we're monitoring estrogen levels and the levels are low. Some people really like looking at numbers, so therefore they will bring that up. The other thing is if you're not getting those feminizing characteristics with the regular doses, with the higher doses, rather than going up to 8 milligrams of estrase, well, why don't we take half your dose sublingually so we get a bigger boost, and then the remainder of it orally, so that way we're mitigating that VTE risk. Post-orchiectomy, because we don't have all that testosterone that we're trying to drive down as far as that phenotype, the dosing is lower, and it's similar to postmenopausal dosing, so 1 to 2 milligrams of the estrase, about 25 to 100 micrograms of that patch twice a week. As far as the cost, so the oral is definitely about a half the price of the patches, but again, those can be eligible for special authority. And then as far as the estradiol valerate, so In terms of the formulation, it's made in sesame seed oil, which is also one of the testosterone formulations. It makes it very, very thick. It also means that you cannot prescribe it to patients with a sesame allergy, and this is something that we do actually have to address in both this and with one of the injectable testosterone formulations. And then it is only available as a compound. There are some local compounding pharmacies that I've had patients be able to obtain it at, but McDonald's is the one that classically a lot of the community recommends to go to, especially because they can ship it over to you. In terms of the dosing, very wide variety of dosing, anywhere from 3 to 10 milligrams once a week is recommended. It can be given either sub-Q with insulin needles or IM. We typically start with 3 milligrams, and the majority of my patients are taking somewhere between 3 to 5, depending on how they're tolerating it. And then the cost is, again, a little bit more because it is a compounded medication, about $75 to $100 a month, so double the price of patches, triple the price of the oral tablets. And then we move on to decreasing those testosterone levels. So we do need, most of the time, a combination of the estrogen as well as an androgen blocker. The mainstay is Spiro. We all use Spiro for a variety of reasons. In my world, PCOS. In a lot of worlds is for cardiology purposes. Spiro, you can see here though, the dose is again much higher than we would use, especially in a heart failure dosing. So most patients will start with 50 to 100 milligrams a day, and we can go up as high as 500. I find majority of patients are needing about 100 twice a day, but Spiro is not as strong as cyproterone, which we'll touch on next. So you can keep titrating the dose, but sometimes you are just not able to get those testosterone levels to target with the spironolactone. The positive benefit of having spironolactone on board is it also does help address some of the male pattern hair loss that patients may have experienced prior to starting on the hormone regimen. It's pretty cheap, which is also really nice, about $20 to $30 a month. And then the cyproterone, so aldactone. A lot of patients like talking about it. I find that there must be something on the Reddit boards about Cipro because a lot of patients do bring it up more commonly, especially in the last few years. We want to use the lowest effective dose. So cyproterone is a very potent progestin. In the fact that it is a potent progestin, it decreases the LH levels and then therefore decreases the testosterone levels. By the virtue of being a potent progestin, it is also more likely to be thrombotic. It has been associated with meningiomas, and it also, through the negative feedback loops, causes an increase in prolactin. So this is something that we have to monitor, and we'll touch base on prolactin in a couple of slides here. The cyproterone tablets come in 50 milligrams, and you can see the dosing here is start with 12.5 milligrams a day and go as low as you can. So very often these patients are taking a half a tablet every other day, or they're taking just a half a tablet daily. I have a handful of patients that just kind of crush them up and they take whatever amount of a quarter of a third that they can every day. It's whatever they're able to get in at that lowest dose. And then in terms of cost, it's about twice the price of spironolactone. It is eligible under special authority. And then finasteride. Finasteride we use very rarely. It's usually an add-on. It is eligible for pharmacare special authority as an add-on to spironolactone if we are trying to maximize those anti-androgen effects. It can also be added to slow that androgenic alopecia. So for some patients that have had an issue with this, leading up to starting hormone therapy, sometimes adding the finasteride on top of the spironolactone can help a little bit with decreasing that hair loss. Typically, we're giving the really small doses, so 1 milligram every other day or a quarter of a 5 milligram tablet every other day. And the other option is using a higher dose without a blocker. So that is definitely possible, trying to do as high of an estrogen dose as you can, mitigating risk factors, to try to suppress those androgens through negative feedback loops. I find that that is not as well effective unless patients have been on estrogen for quite a long time, in which case they're getting some chronic suppression in the background. And then a few notes on progesterone. So I think I have a bias against progesterone, having whined and complained my entire way through a first trimester with twins. But progesterone does have a lot of negative side effects, and the data behind actually using it is not the greatest. So in terms of progesterone, I apologize. I copied prometrium twice. I meant to write prometrium and Provera, which we're very often using in our postmenopausal population. Sometimes we're using it in our POI population. And you can see here the dosing is exactly the same. So we're starting with the prometrium. We start with 100 milligrams QHS, and you can titrate up to 400 milligrams QHS. I write QHS on there on purpose because progesterone can make you feel really, really tired. So in our women post-menopause, cis women post-menopause, we're using this very often to help with sleep disturbances and asking them to take it at night, especially at these high doses. If the patient is taking it in the morning with their estrase or Spiro, they may just be feeling really groggy in the day, and a simple fix could be telling them to take it at nighttime. Provera is a lot cheaper, so you'll see here prometrium is about $70 and $90 a month. Provera is usually less than $30 at the lower doses. The dosing is anywhere from 5 milligrams BID to 15 milligrams BID, so from 10 to 30. Progesterone in the studies has not really been shown to create much of an effect. Sometimes it is used to augment breast tissue development or nipple development. I find it's very person dependent on how patients respond to taking it. The negatives of progesterone, besides the fatigue, is also the water retention, the higher risk for depressed mood, and it is also a weak androgen. So in some ways, we're taking a vulnerable population and further affecting the way that they are experiencing life, and that may not be positive. I would say in my practice, the patients that bring up progesterone, we do end up starting it. We'll titrate it. We'll see if we have any changes in terms of breast development. Probably about half of them end up stopping it because we're not seeing much of an effect, and they're having some negative side effects with it. Plus, in this regimen, especially for young patients, it ends up being taking 3 different tablets twice a day. That is a lot for somebody that is otherwise healthy and not regularly used to taking medications. So in terms of expectations, so the way that we see these things happen over the course of the months. It also aligns with how often I'm seeing these patients for follow-up to monitor those effects. A version of this table is on the consent forms that are in your primary care toolkit. So when I see patients for gender-affirming care for that very first visit, I actually have those consent forms printed out, and we go through that table step by step in the same way that I will with you, and that way we're addressing kind of their expectations, how we will monitor, and also the adverse effects to look for. So in the first 3 months, the biggest thing that we're doing is we're starting that anti-androgen to knock down that testosterone level. And very often it's the sexual function that gets affected. And we need to be really frank with patients about this. Their testosterone levels are plummeting. So they may lose the ability to achieve erections. They may lose the ability to maintain erections. And that is something that some patients actually, the longer they are on therapy, are looking for losing or wanting to go away. So sometimes they will ask for increasing those anti-androgen doses if they are having spontaneous erections, because they can be very distressing for them. The next part of this is over the first 3 to 6 months is when we start inducing what you can think about as pubertal changes, and this is why it takes up to 2 or 3 years to actually see the full effect of them. So for the first one, redistribution of body fat, the way that we describe this is rounding out of the estrogen. So you have rounding out of the shoulders, rounding out of the hips. The amount of times I have had patients come back for a follow-up visit at the 3 or 6 month mark to show me what their butt looks like is amazing. It is a very, very fun part of my practice. The other part of this is decrease in muscle mass and strength. So if we share any diabetes patients, they will tell you, sometimes I'll make them download Instagram to do strength training workouts. At home, strength definitely will decrease because we're having less testosterone. But we have lots of cis women that are pulling a lot of weight and able to do those workouts. The way that I describe it to patients is if you are doing that hardcore strength training, you may not notice those muscle gains in the way that you're expecting, but it's not like you're not going to be lift your grocery bag, which a lot of people do have that misconception about losing that muscle mass, especially with all the things that they're talking about in the news about what our neighbors down south today. The next part of this is skin changes. So we're decreasing that testosterone, making the skin less oily. We're decreasing acne. We're softening the skin. The changes usually happen those first 6 months. but the effect of them can take a very, very long time. And then in terms of breast tissue growth, so breast buds typically start to form within those first 3 to 6 months, but it can take 2 to 3 years before we get to the point of mature breast tissue. It's rare for patients to reach Tanner stage 5 appearance with just hormone therapy. Very often we're also limited by body habit, by their diet, by their physical activity. I always say this as a marathon runner, I can outrun everything, I can't outrun my genes, so here I am with my prediabetes. This is the same thing. We can only grow as much breast tissue as their genetics would allow us to with the hormones. For these patients, I actually see them in the office every 3 months and do Tanner staging, which took me back to my P's years. I'm sad that Brandon's not here because he's one of the people that trained me at Children's during my fellowship to do that. And then in terms of the extent of growth, so the majority, the greatest proportion of breast tissue growth happens within the first 18 to 24 months, so in those first 2 years. If by this time the growth is not sufficient, this is where we have to have that conversation with the patient that this may be the limit to where the hormones will take us. At that point is sometimes when we try a little bit of progesterone, and then depending on what their goals are physically, sometimes referral for chest surgery. And then decreased testicular volume. So volume is typically reduced by about 25% in the first year, and over a long period of time of treatment, about 50% of their original volume. A lot of this has to do with that suppression. And then next is the 6 to 12 month mark. So the two things that my residents always laugh about from doing a rotation with me is that low testosterone is sleep apnea until proven otherwise, and the other one is the life cycle of a hair follicle is 6 months. So you are really not going to see very much changes when it comes to hair growth unless you have been on this anti-androgen therapy with very low testosterone levels for at least 6 months, typically about a year. And a lot of this will decrease. The hair will start growing in slower. It will be finer. But the majority of people cannot eliminate all of their hair growth with hormone therapy alone. For those of you that see patients who have PCOS and prescribe spironolactone, this is very common. Laser therapy, electrolysis, all of these things very often do come into play here. And then decreased sperm production and fertility effects. So very often I have patients transitioning over from BC Children's Gender Clinic or the Three Bridges Clinic into the adult world with me. So we have that fertility conversation when we talk about this part. In terms of testicular atrophy, it will definitely affect sperm maturation, it'll affect motility, and it may be permanent, but the patient may still be fertile. So it is very important to speak with them about the possibility of whether they would want to have children. And then in terms of the effect, we never know. So when I bring this up with my patients that are coming in from the peds world into the adult world, I always bring up that we in Surrey are actually very fortunate that Sean Tregoning, who is the doc working at Olive Fertility, is one of the gender-affirming providers and was seeing a lot of the patients I see now before I had started. He had transitioned the majority of his practice to Olive, and I've had a few patients where I get the notes back saying, you know, I started this patient on hormone therapy 10 years ago, and here they are now for fertility preservation discussion. So it is nice that we have somebody that I am very comfortable with referring patients to, knowing that they will be able to provide that gender-affirming care in such a very sensitive topic. And then things that have no effect. So the hair that has been lost, typically we cannot grow back. And then the other part of it is testosterone irreversibly thickens the vocal cords. So that we are unable to undo those changes with medical therapy. Very often speech-language pathologists are very helpful in helping patients with voice training. All right, and then goals of therapy. So what we're targeting is the female reference range on your life labs or your hospital lab reports, which is essentially a testosterone level of less than 2 and an estradiol level in the average daily premenopausal range, which falls somewhere between that 300 to 800 mark. When you're looking at the labs, if the patient's gender marker does not align with the type of hormone therapy that they're on, you may be getting different ranges. Very often come into this when we're looking at the hemoglobin. Very often this also is important when we're looking at prolactin. So I was working with residents on call last week and I had somebody that was going through a referral with me, and we were talking about the prolactin levels. This patient was on feminizing therapy. They were also taking cyproterone, and their prolactin level was 24, which was flagging on the lab because the upper range, normal, if there's an M gender marker, is actually 20.2. But if you have an F gender marker, that upper range is 28. So for somebody on an estrogen-based regimen, we would expect that that prolactin of 22, 24, 26 is still within normal, even though it's flagging. And that is something that I sometimes discuss with patients that look at their labs, so that they're not coming in anxiously thinking that the cyproterone has induced a prolactinoma. And then same thing with the hemoglobin. You'll very often see that they're flagging as anemic or low hemoglobin, again, because the normal range should be shifted down. And then what do we monitor? So the baseline labs, basically all the things that could go wrong or could go right. So the blood counts, the liver function, the renal function, and electrolytes specifically for spironolactone. We always think about potassium when it comes to spiro. There's been some evidence that has come out on from the PCOS population, showing that we're reusing spiro in healthy patients with normally functioning kidneys with no other comorbidities at these high doses. The potassium levels essentially don't change. And then other things, I'm a diabetes doc. I love the A1C and the lipid profile, so I check those. And this is something that can be affected by the hormone therapy, so we should be monitoring that. I like to get a total baseline testosterone, total testosterone level, estradiol, and a prolactin. So the prolactin becomes the most important part to have as a baseline before you start that therapy, because we want to see if it's increasing, and we'll talk about how often to do that. And then physical exam, so this comes into that. I'm using physical exam in this slide as that Tanner staging part of things. In terms of the labs, like I said, I see these patients about every 3 months for at least the first year, sometimes for longer than that, every 3 months, depending on if we're tailoring the therapy. The labs at the 3-month mark is when we do the initial labs after starting the hormones. So very often it ends up being the same baseline labs repeated. You see prolactins in gray. Doesn't necessarily have to be checked right away, but it's nice to see the effect. Some guidelines and some recommendations previously used to say check at the 1-month mark, check at the 6-week mark. The Endocrine Society has actually changed their view on this. If we're checking before the 3-month mark, the hormones probably haven't reached steady state yet, and we're just chasing numbers and making adjustments based on numbers, not the actual effect that patients are experiencing. At the 6-month mark, we essentially check the same labs. At 9 months, that is mostly more for tinkering, adjustments, pushing the hormone levels a little bit further. So very often the labs that we're checking are more just the liver function. If we've increased therapy, the renal function, if we've also increased the anti-androgen, if they're taking spiro, and then the prolactin level. And then at the 1-year mark, you want to check everything again. After the first year, if the patient is stable, if their hormone regimen is not changing, you could stretch it out to about every 6 months or once a year, depending on your comfort level and their comfort level with the monitoring. If we share patients, you know I love to hoard my patients, so I will sometimes see them every 6 months for a couple of years until they are feeling comfortable, I'm feeling comfortable, their family doc is feeling comfortable with their hormone therapy, and then we stretch it out. And I always have that conversation with the patients when we go from, you got to know me really, really well for the last 2 years, and I'm telling you I'll see you in September. What is going on? And the point of this is we don't want to over-medicalize it. Right? I had a patient yesterday who is a patient of Dan Metzger, one of the other peds endos at that gender clinic in BC Children's. And we were talking about support, which is part of my regular intake with these patients. And he thought about it for a second. He says, frankly, I don't even think about my hormones. He's like, when I started, that day of doing my testosterone injection was so exciting and we were getting my tea. And now it's the day of the week I have to poke myself. And we want patients to feel that way. We want this to be part of their regular life and not like they're being over-medicalized by the system. These are the consent forms. You have copies of them in your toolkit. There's copies of them on Transcare BC. I am always scan these into our EMR so that way I can print them for my patient charts. And like I said, for the very first visit, if we're just starting somebody on hormone therapy, I actually book those for 45 minutes so we can have this full conversation, go through this consent form. I send them home with the consent form. We don't sign it with the baseline labs, and then I bring them back a couple of weeks later so that way they've had the chance to go through it, look at it, bring up any questions, and then once we get those labs in, then we start. Now we're going to shift gears a little bit. So into our masculinizing regimen, the other specialized focus of my practice is male hypogonadism, so I talk about testosterone all day long. And for any of you that do prescribe testosterone, you will see a lot of these regimens are exactly the same. So testosterone drives that phenotype, which also means that in masculinizing therapy, there's only one medication for us to think about, and that's the testosterone. If we are able to provide patients with testosterone, we're able to induce those characteristics by the stimulation of the androgen receptors, and then by virtue of negative feedback loops to the pituitary, the estrogen levels decrease. And this is where we see things like menses cessation. In terms of testosterone-based hormone therapy, when I gave this talk 5 years ago now, there were a couple extra rows in here. They've all been taken away, sadly. In terms of the patch, we used to have Axteron, which is the deodorant, and Natesto, which is the nasal spray. Natesto, I did not put in these slides, but apparently it is coming back, if not already available in pharmacies. The trouble with Natesto is even though it is a nasal spray, it's sometimes BID or TID dosing, which isn't the easiest to convince patients into if they're having to spray it in their nose 2 or 3 times a day. The positive effects of that intranasal testosterone is you have a smaller stimulation when it comes to the increase of testosterone and androgen receptor stimulation, so you're less likely to see troubles with polycythemia. So if it does come back, hopefully this year, that would be a great option for this population as well, especially for people that are running into troubles with that higher hematocrit. So the options we do have available, which actually I should take this side of the table off for another 2 weeks because all the injectable testosterones have been on a shortage for about 2 months now. Then we have testosterone cypionate, which is testosterone, and testosterone enanthate, which was deletestrol till about November when they discontinued it. So enanthate is still available in the generic form, but deletestrol, the brand, is not. The difference between the two of them. So cypionate is in cottonseed oil. Enanthate is in sesame seed oil. There are a couple of differences because of that. The sesame seed oil, we have to ask about sesame allergy. It's also very, very thick. If you've ever seen or injected enanthate, it is like injecting molasses. A lot of these patients are doing small doses, small volumes, and very often sub-Q. So one thing we always talk about is running that vial under some hot water just to make it a little bit easier. Just practical tips for them. Even though it says intramuscular injection, these testosterone formulations can be given either IM or sub-Q at the same doses. So the sub-Q injections, it actually didn't get put in the toolkit. I was thinking about this last night. Transcare BC has a really nice one-pager about how to do the sub-Q injections that I have scanned in my EMR that I print off for patients. We practice on Sophie, who's my stuffy dog, and the patients really like being able to try it with me on the stuffy in the clinic before they're actually doing it themselves. I've had some patients bring in their mom because she was going to do the injections, and then they come in for the follow-up and they're like, I'm doing it. It's awesome. It's easy. So you do get to experience the differences in this, not even only in my diabetes world when it comes to injections. In terms of the dosing, so, I did want to mention one thing. We'll talk about this in the cases, but the cottonseed oil. Cottonseed oil is procomedogenic. So patients that are taking testosterone cypionate are actually more likely to have acne and acne breakouts, as well as oily skin, and develop cystic acne, rather than patients on enanthate. So if somebody is on cypionate and they're having troubles with it, switching them over may help. I actually spoke with one patient yesterday for a very first visit who was switched from deletestrol when it was discontinued to cypionate. And they were telling me when we were going through the medications they're taking that they're about to start Accutane because over the last 3 months they've had all these breakouts. And then our intention is essentially whenever we can actually get some enanthate in, we're going to try to switch them and see if we can help. In terms of the dosing, very similar to the dosing that we use in the cis men. Typically, we'll start with weekly dosing in the gender-affirming care regimens, whereas with male hypogonadism, typically the dosing is once or twice weekly, or every 1 or 2 weeks, so a little bit stretched out. The reason that we're doing it weekly in this population is to minimize the peaks and the valleys of it so you have a more consistent effect and less fluctuations, which some patients can actually really, really feel. In terms of the dosing, so we'll start with anywhere from 25 to 50 milligrams once a week, which would be the same as 100 milligrams every 2 weeks as a typical regimen for male hypogonadism as well. And then maintenance dosing is anywhere from 50 to 100. I find most of my patients are taking about 40 to 80. It's kind of the range. The range depends on several things. So one of them could be their body habitus. And then another one is the way their body metabolizes the testosterone. So some guys need very, very high doses, some don't. It really depends on the person. Unless you're monitoring it, speaking with them about the changes, you're not going to know. And then whenever they decide, or if they decide to go ahead with gonadectomy, so oophorectomy, the dose can often be decreased just to keep those serum testosterone concentrations at the target level. Very often, maximum masculization has been reached after about 2 years of therapy. And at that point, there's been enough pituitary suppression where you can actually try to titrate down that testosterone dose, especially if you're seeing some of those LFT changes or changes in terms of cholesterol levels, or they're letting you know I feel a little too aggressive or a little too edgy. After that 2-year mark, you can be more comfortable about decreasing the doses and confident that they're not going to lose a lot of that masculizing effect. As far as intramuscular injections, they are cheap, so about $25 to $30 a month. The vials come in 10 mils. The testosterone prescriptions, as you all know, are so highly regulated, and inevitably, every time I write one, the pharmacy writes me back asking me to clarify it because everyone wants something different in it. The vials are 10 mils. The vials expire after 56 days. So when you write the testosterone prescription as far as how often to dispense it, I've frequently written for people that are taking 1 ml a week, 1 vial every 60 days. Pharmacies will not dispense it that way. So you actually have to write it for 1 vial every 30 days because of that expiration date. Some pharmacies have let me get away with it. Some are really causing a pushback. I actually had a patient yesterday ask me if they're allowed to use that vial on day 58. So it does become something that we have to think about in terms of the practical approach of it. And then when it comes to testosterone gel, so we used to have patches. Patches were great. You put it on, you take it off every day. Now we're doing gel. Testosterone gel, if you've ever used it or seen it, it is about the consistency of hand sanitizer. So not all that pleasant as far as it's not really a lotion. And we also have to be very frank with people about where it gets put on. I've heard a variety of things that have been read online or have been told by some compounding pharmacies. The testosterone gel goes on the upper arms and the upper chest. Now, one trick that I have learned from doing gender-affirming care for the last few years is putting it on the belly somehow can result in a little bit better absorption. So I've had some patients tell me that when they switched it over to the belly, they're getting a better effect of it, and we actually see sometimes the levels do go up. In terms of the gel, it comes in 2 options. It's either a meter dose pump or packets. The packets look literally like McDonald's ketchup packets, and they get a box of 30 of them. The gel, it is 1.25 grams per actuation, so 12.5 milligrams. The normal starting dose is anywhere from 2.5 to 5, and we can go anywhere from 2.5 to 10 milligrams a day as far as the gel. It comes in the 2.5 and the 5 packets. And then the gel is a lot more expensive. I'm missing a 0 there, but it's about $130 to $190. So Androgel, the brand, is $190 a month, whereas the vial is $70 per vial. So it makes a really big difference. And then if you are able to write generic, so on the prescription, if you write testosterone gel 1%, not Androgel, the brand, it's about $130. So still very expensive, but it knocks out about a third of the price. Gel is eligible for pharmacare coverage in extenuating circumstances. So both the intramuscular injections, even though they are less expensive, they do fall under special authority through pharmacare. So if you submit special authority request, and literally I will show you later on the slides, and it's also in your toolkit, you have to write for treatment of gender dysphoria. That is the criteria to have it approved. Testosterone gel is very hard to get approved. Again, the price. I have had patients with needle phobias or patients who have had persistently elevated hematocrit while on testosterone. Those are the two cases where I've been able to secure special authority for the gel. Unfortunately, they only approve it for a year. So every year, about 10 months after that approval, I have to have a task to myself to resubmit that special authority through pharmacare again. Sometimes you will get pushback if you just say needle phobia and don't explain it. I was specifically asked to write the way that patients respond to blood draws, the breathing techniques that have been used. I did get lifetime approval for somebody where I wrote that they had to bring a stuffy to their lab draws. So the things that the more the patient can tell you about their anxiety when it comes to that needle phobia, the more likely you are to get the approval. The handful of patients I've had the special authority on, I do always write this will be lifelong or long-term therapy. One of them has had lifelong approval so far. So we'll see. And then in terms of the post-oophorectomy dosing for the gel, it ends up being the same thing as the injectables. We try to minimize the dose if we can or if we need to keep those levels in the normal range. Okay, so as far as the expectations, so this is the same table, but for the masculinizing therapy. So the initial response we see is from that higher level of testosterone. So skin oiliness, the acne that we've just chatted about, typically happens in the first couple of months. Maximum effect about a year or two out. Fat redistribution, so this is squaring out of the shoulders, narrowing of the hips. Again, this is more of those changes we think about with puberty, so it does take a long time for them to fully get effect. Cessation of menses. So this is one of the things that happens quite early in terms of the therapy, and many patients are exactly looking for this. So menses can be very distressing, very dysphoric for this population of patients, and when they stop, it is a party in my office when they tell me that they are no longer bleeding, because they all have names for their monthly bleeding, and it is a lot of fun to say, you know, so-and-so is gone now and we're never seeing her again. In terms of the cessation of menses, you're more likely to get it with injectable testosterone because you get a bigger peak of the T, but spotting is more common. So again, because you're getting the up and the down with the injectable testosterone, whereas the androgel is giving you a daily dose, sometimes on those trough levels, or if the dose is not quite high enough before the next injection, you may get some spotting. With the gel, though, you are less likely to get such high testosterone levels, so it can take a lot longer for menses suppression. I didn't talk about oral testosterone androgel. This is more popular in the gyms than it is actually prescribed. It is not as hepatotoxic as the older oral formulations of testosterone, but androgel you have to take multiple times a day. It needs to be eaten with a very high-fat meal, and it has very variable absorption. Only about 50% of people who are taking oral testosterone for gender-affirming care actually end up getting any menses suppression at the 6-month mark, whereas with injections and androgel, you're usually there by that point. And then the other parts of this, so we can definitely see clitoral enlargement. The degree is very varied. It is in the degrees of less than a centimeter. So it is in millimeters in most people, but again, genetics are different. Everybody's body is different, so you can see different degrees of growth. You can also see different degrees of growth with different formulations. So again, if you're getting a bigger upswing more consistently, you may see more growth if genetically predisposed to it. And then vaginal atrophy also can be an issue. This can be very distressing for patients. Their sexual function can be affected. They can have genitourinary symptoms. And I love using this table and this point to have the conversation and the broach of how to say the word vagifem to somebody that is coming to you for gender-affirming hormone therapy. that is masculizing. And we make it into a joke. So essentially, a lot of these patients have a hard time bringing this up. Sexual dysfunction, already a vulnerable patient population, can be difficult. Most of my patients realize I'm just a tired mom coming in my office to drink my coffee hot. So after a few visits, they're actually willing to be able to talk to me about this. And we do have the option of using internal estrogen. So internal estrogen is not systemically absorbed. It will not affect those masculizing effects. It's not going to increase that VTE risk, but it may help with things like lubrication, with decreasing incidence of UTIs. Up until Imvexxy was approved as a regular benefit, Vagifem was my only option. So the way that I describe it to patients, I'm very frank about it. I tell them this is medication that was marketed at women who are past the age of being able to take HRT, which usually means that they're much older, and therefore they name this medication Vagifem. And then we laugh, and then patients will pick whatever name they want to use for it. Very often it's internal E, and you'll see that in gender-affirming care we talk a lot about E and T. So Imvexxy is now a regular benefit as of May of this year. It is prescribed in the same way as Vagifem, so it's 10 micrograms daily, daily for 2 weeks, and then twice a week going forward. I'm looking at our gynecologist to verify my dosing, but it's a regular benefit, which is a lot nicer because Vagifem is very, very expensive. All right, and then these are the long-term effects. So again, the life cycle of a hair follicle is 6 months. So it will take about 6 months before you're noticing consistent body and facial hair growth, but it can take many, many years before we get to the maximum effect. Scalp hair loss can happen. This is typically with a genetic predisposition for androgenic alopecia, and typically happens the longer a patient is on testosterone therapy because those androgen receptors are acting on those hair follicles. Increased muscle strength and mass definitely will degree on their protein intake, on their degree of physical activity, on their strength training. But we'll see this change usually happen starting at about the 6 to 12 month mark and then going on for many years. Deepening of the voice. Testosterone irreversibly thickens those vocal cords. So as in our feminizing regimens where we cannot affect it by hormone therapy, this is one part of hormone therapy that is irreversible. So if patients wanted to reverse the effects, the testosterone effect on their voice changes is not going to be able to be reversed. This is one of the best parts of seeing these patients very frequently. I always love telling the story to residents. I hope you enjoy it as well. I have a patient who is a very petite on a masculizing regimen, and we were seeing each other for a follow-up visit about 6 months after starting hormone therapy. And I'd called him into the office and we're chatting, and I made the comment to him, I really noticed that your voice is changing. And he looks at me and goes, Dr. K, in person, I sound like I'm going through puberty, but on the phone, I am a dad with 3 kids and a mortgage. Honestly, these are the moments that make this practice so rewarding because you get to celebrate these little wins with patients. I still do dances over A1C's at less than 7, but this is one of these really great cases. And then other things that we'll see is, oh, that's double on there, I'm sorry. The other part of this was just talking about fertility being affected. So again, we don't know the degree of this, and Dr. Justice very kindly shared with me a couple months ago that was it like 25% of patients on testosterone therapy still ovulate? Yeah, 25%. So again, contraception is a very important thing to talk about with these patients. And then in terms of our reference ranges, so we're looking for the target male reference range, which Life Labs is 8.4 to 28.8. If they're going to a hospital lab, it'll be more age matched because it is being done on mass spec, but majority of patients anywhere between 6 and 35, depending on which age group they fall into. And then also paying attention that hematocrit and hemoglobin may flag because of testosterone, but they may also flag because we are using the F gender marker normal ranges and not the M gender marker normal ranges. In terms of monitoring, essentially we're monitoring all the same things, except for more focused on looking at the CBC. Sometimes we will look at LH if the patients are not getting menstrual suppression, just to make sure that that testosterone is decreasing the LH appropriately through the negative feedback loops. And then the one thing you'll see on here that is missing is the prolactin. So in the feminizing regimens, we are giving patients estrogen. We can technically stimulate lactotroph proliferation in the pituitary gland in the same way pregnancy does. So these patients may have tiny little prolactinomas growing, and very often they will have higher prolactin levels. And then in these patients, as far as the monitoring, essentially the testosterone levels, once they're stable and typically at the 2-year mark, there's very little tinkering with it. And I do the same for my male hypogonadal guys I see in the cis world, is after the first couple of years or year and a half of seeing each other very frequently or every 6 months, we can stretch it out to monitoring every 12. And then there's the consent form for this one. And here's the funding. So you see, interestingly, it's only the feminizing regimen that is a regular benefit, and also includes that darn progesterone. But like I said, there are specific criteria you can write on the special authority forms to get coverage for these patients, and they're written right here. They're also, there's a table of this in the toolkit that you're provided. And then this, I think, hopefully will help clarify the black box. That is, when do I refer and how do I refer and what do I do? So if a patient is seeking gender-affirming medical therapy, the next step is completing the hormone readiness assessment. So the hormone readiness assessment, depending on who is doing it, can be a very in-depth report of multiple pages and multiple visits. It can be the Transcare BC form. It really depends on the provider that's doing it. In terms of who can provide HRAs, unfortunately, as an endocrinologist, as my husband likes to say, I know a lot about a little. I do have no training in the ability to do the HRAs, but we have lots of great professionals that do. So family physicians are very much able to. I think we'll talk about this at either later today or at our next session, options for providers to be able to learn how to perform HRAs. You can direct the patient to Transcare BC, which is typically the first thing and only thing the residents take away from hearing this talk, is that we do have Transcare BC available. And then you can also directly refer the patient to providers that are providing HRAs. So myself, if you ever referred somebody to me for gender-affirming therapy, if they haven't had an HRA, I have a little note I like to send back with some of the providers that do it. So Dr. Wallace Wong, who works at the Gender and Diversity Center in Richmond, is somebody that sees a lot of these patients. Melody Priest is another one. In the South Surrey area is Brent Mason. And there is a whole list that can be made available or shared by me if you're interested in it. And then through our working group, Andrew announced this at our last session when my jaw dropped to the floor sitting on stage, that we are actually training some people through the PCN network to be able to do these HRAs, which would be covered. Because that is the biggest part of doing these HRAs, is they are not covered. Very often these patients are seeing private counselors and paying hundreds and hundreds of dollars for getting the HRAs done. Hopefully it'll give you a little bit of comfort in that if you do refer a patient to me without an HRA, and I do send you the note back, I put myself task reminders in their chart every 2 months to see if we've received that HRA, because once we do, we try to book the patient in right away. And this is where we're at. So once that HRA is completed, sometimes they will say hormone therapy not recommended. Sometimes they will say hormone therapy not yet recommended, or this needs to be addressed before hormone therapy needs to be initiated. Sometimes it's family dynamics and safety for these people. So it's very important to have that HRA to really guide how we're going to go ahead with the hormone therapy. But once that hormone therapy is recommended, either you yourselves are able to order those baseline labs and initiate, or you can refer to an endocrinologist. So in the peds population, Dr. Hursh will talk about this, but we have that gender clinic at BC Children's. We have Foundry in Abbotsford. There's also 3 Bridges that will see patients under 18 that live in Fraser Valley. Kelly Matthews and I have an email agreement that once they turn 18, if they live in Fraser Valley, they can be transferred over to me for adult care. And then here in Surrey, myself, Akshay Jain, and Shivi Riar are all providing gender-affirming therapy. If you refer to any other endo in the area, very often, if they're not comfortable with seeing the patient with my tech support, they will either let you know to send the referral over to one of the three of us, or they'll kindly forward it over to my office to book them in. All right, clinical conundrums. Hopefully this will address a lot of the questions that you've had in your Slido. But we're going to start here. So this is actually my very first week on call in December 2017. On the day I found out I was pregnant, I had this call right as I was leaving the office. So it was from the ER. It was a 37-year-old trans feminine woman, patient, who is taking estrays. And ER had called me because the patient had come in with a seizure, and they wanted to start them on carbamazepine. And the question for me was, what in the heck do we do with the hormone regimen? How many of you have thought that epilepsy would be affecting the hormone regimen? Doesn't come up a lot. So very important, because the type of therapy chosen will affect our hormones. So enzyme-inducing AEDs, so phenytoin, phenobarb, and carbamazepine, what they do is they increase the hepatic metabolism of estrogen, so then therefore they lower those estrogen effects, and the patient may have a decrease in those feminizing characteristics. Additionally, they also increase levels of SHBG, and then that way you have less of the active or free estrogen available to actually induce those characteristics. This is similar for testosterone. If you're going to increase that SHBG, you're going to have a lower effect of testosterone. The other part of a treatment of epilepsy is lamotrigine, completely different. So lamotrigine and estrogen are both metabolized through glucuronidation, and therefore if you're giving the patient an estrogen-containing product, the metabolism of lamotrigine can be sped up and the levels could be decreased. So in these patients, either their neurologist needs to be very well aware, or they need to be more watchful for whether that lamotrigine dose needs to be increased. And also thinking about this anytime we're increasing that estrogen dose, because for those first 2 years, we're very often tinkering with those E doses. The other part of this is estrogen is a proconvulsant, and testosterone and androgens in general are anticonvulsants. I have asked this question every single time I've given this talk. Does anybody know catamenial seizures? Nobody's ever known this, okay. Catamenial, these are seizures that occur around the time of menses. And in the gender-affirming care world, catamenial seizures can be completely ceased when menses cease with testosterone therapy. So you can actually treat their seizures with hormones, which is really cool. And then the other question is, what do we do? So you can either monitor estrogen levels, which is something we don't do very often, on a regular basis in patients on estrogen. You can increase the estrade dose in somebody that is on an inducing AED, or you could switch to a non-inducing AED. The one thing everybody wants to talk about, estrogen and VTE. So here we're talking about a 34-year-old trans feminine patient who's taking 3 milligrams of estrase BID, so 6 milligrams of estrogen a day. Developed a DVT after a trip, which included a long car trip and a long plane ride. Doesn't smoke, has no family history. So when it comes to estrogen, it's been established as a risk factor for thromboembolism, especially VTE, due to the early studies on combined oral contraceptives, which have ethinyl estradiol in it. As you know, that is not recommended in this population. So all those studies were done in cisgender women. And you will see here, as I'll talk about some of the data, if we are starting estrogen, again, estrase 17 beta estradiol, less likely to cause VTE. There was a study done in 2008 looking at 2,200 trans feminine patients, and they're looking at them from 1975 to 2006. And they found no incidence of VTE in anybody on 17 beta, which is estrase. Ethinyl estradiol, 6 to 8% incidence of VTE. So again, contraceptives not recommended in this population. In terms of other studies, I'll just give you some numbers here. 1% incidence among about 1,000 patients using estrogen for 5.5 years. And then there was a study that looked at 200 patients. 5% of them developed VTE, but all of them except for one had a risk factor for it, whether it was immobilization, surgery, smoking, or thrombophilia. The way that we mitigate these risks is the type of estrogen that we're using. So oral estrogen affects the hepatic metabolism of the coagulation factors. And this is where we tend to, due to first pass metabolism, and this is why we see that prothrombotic effect. Transdermal or sub-Q estrogen are less likely to cause this. You could also lower the dose. There's no role for thrombophilia screening in asymptomatic individuals. They did this study in, how many patients were there? 160 who were given the 17-beta estrogen for about 4 years, and they found that there were no episodes of VTE, even though 18 of those participants tested positive for a genetic thrombophilia variant. So much safer than the older types of estrogen. In terms of prophylactic therapy, so aspirin is definitely shown to have some benefit in secondary VT prophylaxis, but in general, the data when it comes to benefit and harm is not the greatest. Very often I'm taking my diabetes patients off their ASA, so I'm probably not going to be starting it in this population. Basically the American Journal of Hematology had a review of this about 4 or 5 years ago, and they said there's no indication for routine ASA prophylaxis. A part of this when it comes to mitigating risk is also elective surgery, including gender-affirming surgery. So a lot of these patients will be advised by the centers to stop their hormones for about 2 weeks before the surgery, which can be very dysphoric, very distressing for patients not to have that E on board, and then not started until they're able to be mobilizing appropriately. When it comes to somebody who's had a clot, I've had this conversation with some of the hematologists. Essentially, a conversation with the patient is we need to involve a hematologist and whether lifelong anticoagulation would be appropriate. It's very person dependent. Okay, next step. Another big thing with estrogen, breast cancer risk. So I'd like to thank Endo 2024 for highlighting this as a very big part of the gender-affirming care clinical conundrums. So breast cancer is the most common cancer in American cisgendered women and the second leading cause of death. Cis male breast cancer only represents 1% of all breast cancers. Where our population falls when it comes to trans feminine patients is somewhere in between, a little bit more towards the cis women spectrum. So essentially it's about the risk is very much closer to that of cis women, therefore the guidelines end up recommending essentially very close screening to cis women. When we're thinking about transgender men, so our transmasculine patients, it really depends on whether they do or do not have breast tissue. So transmasculine men who have breast tissue that is intact have the same risk of breast cancer as cisgendered women. Okay, so their guidelines in terms of screening are exactly the same. The risk after chest masculinizing therapy, or surgery, so top surgery, is not really well defined, but essentially it significantly does decrease the risk of cancer, and the radiology guidelines essentially say these patients do not need any screening if they have had that chest surgery. And then in terms of when to screen and how to screen these patients. So it depends on whether they fall into the higher risk or the average risk category. So if they've had a personal history of breast cancer, if they have the BRCA gene mutation, some of the syndromes like Lee-Fraumeni or Cowden syndrome, or any family members that have a genetic predisposition for any type of cancer, these patients would be considered more of a high risk. Average risk is everybody else. So for average risk, for our trans feminine patients, the recommendation is if they've been on hormone therapy for 5 years or longer, to start screening with mammography at the age of 40 and up, and then follow the same guidelines as for cisgender women. If they are at the high-risk category, the recommendation is that you should be starting that screening at age 25 to 30 if they've been on HRT for more than 5 years, and may consider it if they're 25 to 30 but have been on hormones for less than 5. Essentially what we're taking away from this is one relative at an older age being diagnosed with breast cancer does not significantly change the cancer risk when it comes to breast cancer in this population. And then the other thing that I did want to mention is testosterone therapy has no effect on the risk. So whether the length and the duration of testosterone therapy in our trans guys does not affect their risk. It's a matter of, is there tissue present or not? And then the other thing to mention is mammography is the only modality that's been shown to decrease mortality when it comes to breast cancer screening in this population. But trans women have slightly denser breast tissue, so you may not be able to pick up some of those nuances and could consider an ultrasound or MRI if worried for this population. That would be very appropriate because of that density. Okay, and here's the prolactin one. So we've talked about this already a little bit here. So this is a 28-year-old trans feminine patient on estrase BID, as well as cyproterone. Both of these very much like to increase prolactin levels. So we could actually see this because I order prolactin levels a lot. Sometimes cis women, if you catch their prolactin level at the time of ovulation or right afterwards, those levels will be a little bit high. And then we check them again 2 weeks later and they come back to normal. So estrogen does induce lactotroph activity. It can increase prolactin levels to go up. Again, making sure that you're looking at the right normal range when you're interpreting those labs. Very often we'll see prolactin levels increase to that 25, 30, even up to 100 mark, just with therapy alone. Estrogen itself does increase prolactin, but not typically to the levels of higher than 50 in a consistent range, unless they're getting really high doses, sublingual, where they're getting a lot of upswing. It's usually the cyproterone. And cyproterone will contribute to those higher levels. When you're trying to figure out, should I do any further imaging to look for other pathology for this? Things to think about is typically if the prolactin level is less than 100, it's unlikely to be a prolactinoma. So if those levels are over 100, persistently rising despite no changes in therapy, the patient is starting to develop symptoms of pituitary disease, whether they're headaches, vision changes, galactorrhea, those are times to order an MRI. Now, one time I have ordered an MRI in a patient with somebody that is on sub-Q Valerate, who is also taking 400 micrograms of the estrogen patches prior to switching over, plus cyproterone because both finasteride and Spiro were ineffective. And their levels every time we did the labs would just double. It was 20, then it was 40, then it was 60, then it was 90. And they started developing headaches. We did the MRI, it was totally normal. We empirically held the cyproterone. Just for 1 month, the patient wanted to do this. She had actually brought it up to me. We held it, those prolactin levels dumped right back down. So we're pretty consistent with what we're talking about here in that very often it's the cyproterone that's doing it. And then as far as prolactin monitoring, if they are on the same regimen when it comes to the estrogen and cyproterone and things haven't changed after 3 years, you can stop checking it. So the guidelines for BC say we should check it essentially every 3 to 6 months for that first year, and then at least annually for the first 36 months. If it's been normal at that point, you don't have to check it anymore. If the levels are high and it's becoming distressing to the patient, one option would be switching the anti-androgen if we're able to, or sometimes switching the mode of estradiol. So whether they're getting sublingual and oral and switching over to the patches just to get less of that upswing and less of that stimulation. Okay, moving on to some of our transmasculine patients. So this is talking about scalp hair loss after a long duration of therapy in a 42-year-old transmasculine patient on testosterone. The average run-of-the-mill dose of 50 milligrams a week. Options here would be either using topical minoxidil, Rogaine. It's first line, it's non-hormonal, it can promote hair growth without interfering with the masculinizing effects. Sometimes we do use finasteride. So I always have this conversation with the patient, I'm giving you T, now I'm giving you a T blocker. Finasteride specifically is nice because it affects the DHT, which causes the androgenic alopecia because the hair follicles get so miniaturized from it. And we use the doses, like I said, a 1 1/4 or 1 milligram every other day for patients that are wanting to use it. I find the benefit so-so, it really depends on the person. I can't say that there's been anything really impressive with using finasteride when it comes to hair growth in this population, more so than, for example, minoxidil. And then reassessing testosterone dosing. So have they been on hormone therapy for more than 2 years? Can we wean that dose down without making the changes to their masculinizing effects, their testosterone levels, and how they're feeling? A lot of this is having the conversation with the patient of what they're comfortable with trying and what they're comfortable with doing based on our recommendations to minimize that risk. All right, and then hematocrits. So having just reviewed and written the paper on risks of testosterone therapy in cis men, cardiovascular risk, not really an issue. Elevated hematocrit, VTE, actually is. So very often we will see high levels of hematocrit and hemoglobin in patients taking testosterone due to the direct effect of stimulation of EPO in the bone marrow. I always say EPO, like the one Lance Armstrong used to dope on, and a lot of my patients in this population are much younger than me and have no idea who I'm talking about. But essentially, because we're stimulating that EPO, we have to monitor for hemoconcentration. First things first, always rule out obstructive sleep apnea. I didn't realize I'd be a sleep apnea doc when I decided I was going to do testosterone, but I do it in both my trans guys and in my cis guys. A big part of this is we're giving them that testosterone that's irreversibly thickening those vocal cords, which means the stuff in the neck that could be obstructing is increasing. And I do have quite a decent amount of my transmasculine patients who are actually like getting treated with a CPAP for sleep apnea at a very young age without a very high BMI. So in these patients, when we're thinking about erythrocytosis, target hematocrit extrapolated from polycythemia vera data is aiming for it to be 0.52 or lower. So this is something that we track. Typically, if we're going to be trying to aim to decrease it, decreasing the dose or lengthening the interval between the doses can sometimes help because you're getting less of that EPO stimulation. So if they're taking it weekly, sometimes just doing it every 10 days will make the difference. Or even a 5 milligram dose decrease, telling them to go in between the two little lines on the syringe will make the difference in allowing that hematocrit to drift down. You could change route, so going from injectable to the gel. We've talked about all the negative or less positive effects of the gel already. And then phlebotomy, also an option, especially if they're symptomatic, like getting headaches or dizziness, or there's a higher thrombosis risk. All right, and then acne, I think we've talked about this quite a bit today. Essentially, this is androgen driven. You need to be checking their testosterone levels, make sure they're not getting too super physiologic, especially at the midway point. You could switching to doing divided doses. I don't love doing divided testosterone like twice a week because you're getting a lot more of that EPO stimulation. I've been so scared by the Traverse study about the VTE risk with testosterone. Other option would be trying lowering that testosterone dose down, or switching over, like we've talked about, to enanthate rather than cypionate because it is less likely to cause those breakouts. Some patients have used finasteride as an option. I don't really use it in practice. I haven't seen it very commonly thought about or talked about. And you can also affect that masculinization effect. All right, this is a 29-year-old transmasculine patient on T with sexual dysfunction and GU discomfort after 2 years of therapy. So the formal name for this, which we've already talked about this case, is genitourinary syndrome of testosterone therapy, GSTT, which is the same as genitourinary syndrome of menopause, GSM, but this occurs in testosterone users due to the estrogen depletion. And the treatment, like we've talked about, vaginal estrogen. Estrogen cream is also an option. Lubricants, moisturizers that would have a silicone base or hyaluronic acid are also an option. And we've talked about Imvexi. That is all I have for you. Questions?
First one we'll ask is, what form of birth control is typically used in trans male patients who may still be ovulating and need contraception?
Ultimately, we would just give them whatever they're most comfortable with. So I'd say a good subset of patients we see, whether needing it for contraception or menstrual suppression, the idea of taking estrogen might be dysphoric for them. Other people aren't bothered by it. So, I preface it when I give all the options and upfront say a lot of my patients don't like the idea of taking estrogen so that they feel comfortable declining those options if they'd like. I'd say probably most commonly the two options we see are either like the Mirena IUD, which provides menstrual suppression and excellent contraception, with a lot of patients opting to have them put in under sedation, which is something that can be offered through any gynecologist in Surrey. We have a sedation program at the Jim Pattison now, or there's a sedation option at BC Women's Hospital in Vancouver. And the other option that we often see both for menstrual suppression and contraception is Depo-Provera injections. But yeah, at the end of the day, whatever, like any cisgendered female, whatever they're going to be compliant in taking, like that, contraception is as effective as the user input.
Thank you. And we'll just have time for one more question. So if a patient is worried that they may change their mind after starting HRT, what can I share about the short and long-term effects of starting and later stopping HRT?
That's an excellent question. I think the data is so not excellent on being able to answer this. So there's definitely some things that are irreversible that we do have to be upfront with patients about. In the primary care toolkit, I believe it is in one of the forms that you were given, it actually checks off which changes are reversible and which are not. And you can go through them with patients. And definitely the voice changes are the biggest one that I talk to patients about.
Okay, I'm so excited to be here, and it's so heartwarming to see you all here and to be in a venue with so many people. Let's not even talk about the twinkly lights, but I think in a week or so where there's been so much difficulty for trans people, to see this many warm faces in a room learning is just absolutely wonderful. So I'm really excited to be here with you. I'm an endocrinologist at Children's Hospital. I've been working with trans and gender diverse youth for about a decade now, and I'm really excited to take you on a little bit of a journey over the next, I don't know, we'll see. I'm going to move quickly because I know that, it's the evening. We're into the evening, but these are my details, and I'm reachable. So the internet has my email, and you can reach out to me if I can be helpful for navigating the care for a youth in your community. I simply stole the objectives of your whole evening and made them for youth, right? We're going to improve your confidence with youth. We're going to create ease around the topic of caring for youth, but we're going to focus on some endocrine medical care options that are available for youth. We're going to learn where you can find some resources, and then there's going to be some clinical pearls on the slides, which hopefully will be helpful, a lot like the talk you just got, some really high-yield info for you to have. And then we're going to think about normalizing gender-affirming care in the overall context of primary care, okay? Because I think I live on the subspecialty side of this, but I get the referrals from primary care providers who are doing amazing work with the youth that come to them, and I also hear, of course, about the situations that don't go well for youth in primary care. I know which side of the group you're on here, and I'm so pleased with that. So we'll talk a little bit about some roles that primary care providers can play. Okay, so we've got some cases. Youth 1, this is a parent and team present to your office. The parents have recently learned that their child has been using a different name and pronouns at school. They want to be supportive, but they acknowledge they're totally new to this and they're lost. They're looking for some help. I know we've got a group of primary care clinicians here. I'm wondering, has this interaction happened to any of you? Yeah? We've got a few. Okay. So, and probably some of you are here because you're worried this interaction will happen to you, or like, what are we going to do when the floodgates continue to open and we see more youth coming forward asking for help, right? Okay. This is an amazing study, 2019, Being Safe, Being Me. This is the Canadian Trans and Non-Binary Youth Study. This is not youth receiving medical care. This is just youth in Canada. There's a 2024 version that's they're going to be publishing soon. This work is coming out of BC. But it covers all of Canada. There are people represented from every province and territory. And so when they asked trans and non-binary youth about their identity, this is what they said. 12% trans femme. That's not unsurprising. The trans femme youth used to be more prominent because it was pathologized. There's lots of reasons in our society why it may be easier for someone to be trans mask and out openly as that, because stigma still exists for that group of people. But this is what's amazing. So 44% trans mask kids. So this is of non-binary and gender diverse youth. But look at that number, 44% non-binary. So if you're getting into gender care and you're thinking, okay, but I'm still going to think in the binary here, you can't do that with youth anymore. And that means you've got to be open-minded and you've got to ask what's going on and approach with curiosity around what their sense of self is, because it's very likely that they're gender diverse, but it may not be a binary answer of trans guy or trans girl. And here's like a million terms. You can all have these slides, so a lot of them are just for your information, but a million different categories, right? This is our internal data from Children's Hospital. So these are new referrals for gender diverse youth over time. And we all know this curve, I think, because this is what's happening not only here, but all around the world, where we're seeing an exponential increase in people presenting to care saying that they're hoping for gender-affirming healthcare. So you're probably going to get the question, or you're wondering the question, so why are we seeing more people now coming forward? Well, we've got broader acceptance and destigmatization of gender diversity. That's a good thing. We've got compelling evidence that biology contributes to gender identity. So the idea that this is not a choice, right? These are conversations that happened not even that long ago about being gay, right? The recognition by professional mental health societies that being trans should no longer be considered a mental illness. You don't have to go back very far in time to have that stigma. And the emergence of scientific data demonstrating clear mental health and even life-saving benefits of gender-affirming care. And the data stuff is, I'm not going to go heavy into it in this talk because we could be here for a day or a week going over everything. But let's go back to this youth. So the parents want to be supportive and they're new to this and they're just looking for help and guidance. So Trans Youth Can, when people say there's no data about this, Trans Youth Can is our multi-center Canadian prospective study looking at youth presenting for hormone therapy. Okay, so this is data, this is ongoing. And this is a really impactful slide from that study. This is in the slide set that you can have. And what this is showing, just look at the curve, right? The curve is furthest to the left at the top, and then next, and then furthest right on the bottom. And so the top is where youth first recognized themselves that they had a gender issue. Okay, so they knew it internally. B is when they started coming out socially, meaning telling friends at school or whatnot, and maybe starting to say that to a parent that they trust or both parents. C is when they show up at your door looking for medication. So by the time a kid knocks on your door, they've already been on quite a journey. And I think that's important to recognize. It's also important to recognize that their parents have been on less of a journey. Okay? So you've got parents who are like a little deer in the headlights, and you've got a kid who's saying, come on already, and you're there, hopefully feeling comfortable, but maybe not. But you're learning that you've got lots of people and resources that you can reach out to. Okay. This is from that Being Safe, Being Me study. This is humbling data. So while many youth have a primary care provider, over a third said their PCP didn't know their gender identity, and only 1 in 5 were comfortable talking with their primary care provider about gender. And almost half said they didn't get the physical health they need. This is gender diverse youth about healthcare. They're saying they didn't get the physical health they needed. And they don't feel, and 3/4 not getting the mental health care they need. So this is a huge need. You can easily fill this gap, right? This is low-hanging fruit stuff. And why would a youth not go to care? Half are afraid of what a doctor would do or say, and half have had negative experiences in the past. So predating even your first interaction with someone, they might have had a bad experience somewhere else. And we know these youth are vulnerable, but we also know that youth who are with supportive families and safe schools do much better, and they're less likely to be suicidal. But 70% of trans youth have self-harm history. 34% have considered suicide in the past year. And look at the staggering number, right? 17% have attempted suicide in the past year. Those numbers are shocking. And it shows, like, again, what a role you can play as a primary care provider in terms of building a strong community, building support for parents, building support in schools. We're not going to go too much into the weeds here. Reach out if you've got a kid and you're trying to figure out how to navigate care. But in our program, when we get referrals, we have an intake visit and we help people navigate. So if we get a referral and they're in Abbey and they'd be way better for the Foundry, we help point them in that direction. But they meet with one of our nurses or social workers first. So we can help navigate if you don't know the wayfinding path, if we get a referral from you. We do work with the context of a readiness assessment. I'm not going to go deep into that, but there are psychologists and other healthcare providers who do, in the province, who do hormone readiness planning. We have a referral form. You know, one of the simple questions is around puberty. Is the youth in puberty or not? That's a step that can happen before coming to us and helps with the triage. And there's an amazing website that you can find easily by Googling BC Children's Hospital Gender. Tons of resources, consent forms, information on medications. I thought I'd bring a bit of voice of trans youth into the talk tonight. So this is just a quote from someone that I worked with. So this is probably the counter to that, like, why are you all coming forward, and why are you putting this on me as a care provider? You're putting me in an awkward position as a care provider because you're so whatever and you want to be, treated special. Well, this person said, we are knowingly subjecting ourselves to mistreatment, bullying, harassment, threats, and abuse, an unsupportive society, family, and group of peers, harassment and unjust treatment. What person would choose to experience that in life? In other words, acknowledge the hurdles that the kid sitting in front of you is facing as they come forward to talk to you about this stuff. So care of youth is important, and it is a bit different than adults because youth have the ability to have their physical body aligned with their gender identity, and youth are in a stage where their bodies are actively transitioning through puberty, so this is a time-sensitive area. Physical outcomes can be much better if you're treated before you have breast development for a trans guy, before you have beard growth or deepening of the voice for a trans woman. We can prevent the developmental problems that happen when you have to go through like your whole adolescence and then young adulthood with a discrepancy between your body and your mind. We see youth flourish when this care is received, and we know that youth are suffering when they don't get it. So one of the first things you need to know is, okay, so when does puberty happen? Because we don't actually do any care other than just supportive things, navigating social stuff, schools, and community, until puberty happens. So what is the timing of puberty? And many people here will know that breast development starts around age 10 and a half. Okay, testicular enlargement starts around age 11. Put a 2-year window on either side of that, and you know that anyone who's walking in the door around even 8 or 9 could be in early puberty, and so that's something to be thinking about, and that may well be when a family starts knocking on your door. Kids are growing, they're making strong, healthy bones, they're going through the physical changes of puberty, they're going through the developmental tasks of adolescence. They're still solidifying their gender identity. And by the way, they're dealing with the school system and they're dealing with their families. So this is a complex environment they live in. If you take a message tonight, one of them is refusing timely medical interventions is not benign. It can prolong their sense of gender dysphoria. It can contribute to an appearance that could provoke abuse and stigmatization. So doing nothing is not a neutral option. Okay? You may not be the right person to do something, but doing nothing is not the right option. And so even simple wayfinding and information provision is a really positive step. This is another comment from a youth. My body is mostly my past self and not my current self, and it's difficult to live in it. I am misgendered every time I go out, and each time that happens, it's like I get struck by lightning. Here are some resources. WPATH, the endocrine guidelines, the adult guidelines in BC. These are two other great resources. There's a primary care toolkit, and there's also a race line. So these are resources that you can use as a provider. Okay, I'm going to give you a couple cases just to think about. A 10-year-old person assigned female at birth presents to your office with his mother. He's long-standing gender incongruent since childhood. He's been living as a boy since he was 6. Okay, so 10-year-old child living as a boy since he was 6, and now they're knocking on your door. So what do you think's on their mind? What's happened recently? Puberty. Yeah, totally. Totally. So everything was kind of fine, right? School, the child's probably stealth by that point, or everyone has just like forgotten the body that they were born into. The kid's just integrated well, but now puberty's happening and it's kind of time to freak out. So in a transmasculine person, breast development's the first sign, and in a transfemme person, testicular enlargement is the first sign, okay? A note of caution to be careful around physical exams. Make sure you're getting consent, make sure you're explaining what you're doing if you need to do a puberty exam, but it can also be helpful to understand where someone's at and what's going on. Okay. I don't think I'm going to go into a lot of detail about exactly like what gets you to this point, but you know, has the child had a long-lasting, intense pattern of gender nonconformity? So this has been going on for a while. Do they clearly have discomfort in their bodies? There's actually a lot of kind of discussion about that now because, you know, they may actually have a really positive experience with some social transition in supportive communities. So that sense of gender dysphoria is different for different people. Are they in an okay place in terms of mental health and physical health to be making decisions about this? And do they have the capacity to give consent to this treatment? Those are complex things. As a frontline person, unless you're going to become specialized and work in this a lot, you're not making all of these decisions by yourself, probably. The adolescent needs to get lots of information and know the risks and benefits of what's going on. And then have they given informed consent? And we can, maybe if there's time for questions afterwards, we can talk a little bit more about what that looks like. Okay. And so the medical option here for this youth would be, would suppressing puberty be helpful for them? Would using Lupron, which is a GnRH agonist, it is a long-acting pause button that stops the production of LH and FSH and therefore stops the gonads from making sex hormones. Okay, so would stopping the production of testosterone or estrogen be helpful for this youth for a period of time? We tend to think of this actually as a reversible medication. We use this in kids with brain tumors who go into puberty early, and we can just like that use it here to prolong the time before puberty starts and to give a youth a longer time to make decisions. It's an injection that happens every month or every 3 months. There are differing doses. It's interesting, it requires special authority, which an endocrinologist doesn't require that, but so if you were a primary care provider prescribing Lupron yourself, you would need to go through the process of obtaining special authority. So why would we use, Lupron's like the big gun puberty blocker. You talked a little bit about Spiro or Cyproterone or whatnot for transfemme folks. Lupron is the medication that absolutely stops puberty dead in its tracks and takes someone back to a prepubertal state. Doesn't change effects that have already happened, but hormone-wise, you go back to having no testosterone or no estrogen around. It allows the youth to then focus on the social aspects of transition and develop their decision-making capacity. So in a way, it's providing a little bit of time before you're making irreversible decisions, something like changing your body in a noticeable way long-term with testosterone or with estrogen. We think about bone health because we're delaying puberty, so we try and optimize bone health. We don't often see sterile abscesses, but that can be a problem. If someone comes to you, they're on Lupron and they have a lot of swelling and soreness and redness, it could be a sterile abscess. little bit of change in mood as we're swinging hormones in any direction. We notice that, so we often caution around that. And in someone who has like a trans guy who has late pubertal levels of estrogen around, you're effectively putting them into menopause by taking away the estrogen all at once. So sometimes people say that doesn't feel very good initially. Sometimes, though, the euphoria of getting rid of that hormone that's changing their body does feel pretty good. So it's kind of a grab bag of different responses. And we always talk about fertility. Right from the very start, I talk about fertility. So even though I'm using a reversible medication, and I know that if the youth stopped it in a few years, everything would be absolutely fine with their fertility, I still talk about fertility because the reality is that many of these youth who are presenting really early to go on blockers have long-standing sense of their identity and may well continue to then go on to hormones and on from there. So we talk about this with the youth and with parents. Okay, next case. This is a 15-year-old, assigned female at birth, identifies as male, and distressed with puberty. So different than the first kid. The first kid was 10, probably very little chest development. Lupron would effectively save that person needing to have surgery later on to remove breast tissue. Major life-changing medication. This is a 15-year-old who's distressed with puberty. And so we're going to do a puberty assessment, and then we're going to address their goals of care. And this youth wants to stop further chest growth, have bleeding cessation, and then they want to have masculinization, which is testosterone. So sometimes something that you wouldn't even think twice about doing for a cis kid can be a really important medication therapy here. So using a pill that can stop bleeding for a mid to later teen person can actually be really, really helpful. I tend to use the progesterone pills quite regularly because they're easy to start in kids who are still, or teens who are still deciding what their long-term plan is going to be. They're easy to start, but they're also easy to stop. They tend to decrease bleeding if you take them consistently over time, and that works well. Options like IUD and whatnot are amazing, and I often connect to a gynecologist if someone wants to work through more complicated routines for bleeding cessation. Many teens, I find, don't want to take an estrogen pill, even though I think they work better for bleeding cessation. So this person that we're talking about started bleeding a couple years ago. They think their chest development has slowed. They're binding 10 or 12 hours a day, so they're compressing their chest with a binder. And they hate their bleeding. It reminds them of their female body. And the parents are not really sure about any of this. So this is, I think, what I probably am setting up here, that this is the perfect youth to do something temporarily to stop bleeding, and then it's also a youth who's really, their main goal there is they're working toward testosterone therapy. And over time, testosterone will stop their bleeding anyway, so that will lead to that outcome. This is from the Endocrine Society guidelines. So the historical age for starting hormones used to be 16. If you went back a decade, that's probably because the Dutch studies made everyone go on blockers until they were 16, and then they gave them hormones. I think many of us who work with youth realize that that doesn't make a lot of sense physiologically. It doesn't make a lot of sense to put someone through hypogonadism for a number of years before allowing their body to see some sex steroids. So as it notes there, even though there's not great data in youth younger than 13 or 14 years, that's become probably more like the lower threshold for youth right now. I've got notes on dosing here, but if I start testosterone on a youth, we do it subcutaneous, and I start gradually and go up from there. So our typical dose now, I would do 20 milligrams weekly to start. But in a youth who's neurodiverse, complex mental health, or who just wants to go a bit slower, or maybe a non-binary youth, I might start at 10 milligrams, which is really like a tiny dose when you think about a full adult binary dose of 100 milligrams weekly. And honestly, we don't usually make changes in the kids more than about every 6 months because we're giving them time to adapt, and they're doing their work of social development and all of that stuff too. I think you got a lot of this, so I'm not going to go over the permanent changes of testosterone therapy, but the slides are here. One thing I'd say for youth, because one of the big questions, okay, well, what if they make the wrong decision, and what if they regret this forever and ever, and what if they come back, the parent says, and what if they come back to me and then they'll hate me as an adult when they're an adult? I mean, honestly, we don't see that. We've never seen that in years and years. It just, that doesn't exist, or at least it's very, 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 very rare. But we do reassess our goals throughout. So the door is always open for a youth to come back and say, hey, this isn't feeling perfect for me. This medication, I thought it was right for me, but it might not be. I don't want to go up anymore, but I'm happy on the lower dose, whatever. We let that happen. So making sure that we're being responsive. And that takes us from making like a one-time decision to change your life to actually just a million points along the way that you're continuing to decide if the medication you're on is the right medication and at what dose you want to be on it. It takes it from like a big worrisome thing and puts it into many small decisions. And that kind of actually like lets a bit of the air out of the balloon too for the parents who are very worried about this when they realize like, oh, this is actually just something that gradually happens. We're talking about transition over a number of years. Okay, number 4. A 16-year-old assigned male at birth is non-binary, trans femme, and is having distress with masculinizing puberty. So I said 16-year-old. So this is an important case for you because the idea here is that, well, for the trans guy, we say, okay, we know puberty happens earlier in trans guys, right? They get their chest development, they've started bleeding, so they've seen estrogen for a number of years. Taking away all the hormone doesn't necessarily help as much as simply helping them on their journey toward testosterone therapy. But for trans femme people, masculinizing puberty lasts for a long time. Think of a teenage cis guy in your life, and then think of a 25-year-old cis guy. They look very different, right? Their beards fill in, their shoulders get wider, their jawline develops. So you can actively, puberty is actively happening over a much longer time frame. So an older teen may still really benefit from taking away the testosterone entirely. So we still use Lupron quite frequently in this population. And if Lupron's not the right fit, maybe something like spironolactone is. But we definitely consider the GnRH agonist well into the puberty time frame for these kids. Okay. What happens to a trans femme person when you use Lupron? Well, there's lots of benefits. They get less erections that can be quite distressing, right? They have lower libido, which can also be quite distressing for some people. It stops the hair growth on their face. It stops the lowering of their voice. Many of these teens might not have an Adam's apple yet, so you're stopping the development of that. And we're actively talking to them when we're thinking about that, about doing some sperm freezing beforehand if they're willing to. It's not a palatable option for everyone. And they may well be on a path of working toward feminizing therapy too. This is just some info on Spiro. So for this youth, they were shaving their face twice a week, so not 7 days a week. Their voice had lowered somewhat. The Adam's apple was already there. They were quite bothered by the erections. And so they started on Lupron, and their testosterone level dropped right down, so they're doing much better. And the youth and the family were hoping to work toward estrogen. I think you probably went over dosing. We started like really little doses that probably seem really silly to the adult providers, but that's because we induced puberty in kids with Turner syndrome and kids with hypopituitarism and all these things. So we're used to starting like a 0.5 milligram a day of estrace and then going up gradually over time. I use patches, which are more expensive, but I use patches in people who are higher risk, people who are smoking, clotting disorders, stuff like that. And the data on the patches is really nice for suppression of testosterone. Okay, I won't go over all the effects of estrogen. Okay, I threw in one last case for you, because this is one that does get bumped back to me quite often. So last case, a 15-year-old trans boy asks you for information about top surgery. Has anyone here had someone walk into their office and say, I'm interested in surgery, or I've got a document that I want you to do the referral for me for surgery? Has that happened yet? I see a couple of nods. Okay. I get it. It comes back. We really try to encourage family physicians to be involved in this work, and the reason is that you're the family physician. So if a youth goes for top surgery and then they have an infection, or there's, I don't know, some drainage or something, being able to go somewhere and say, hey, I've got a surgical incision and I'm worried about it, can you look at it? It would be really good if their primary care person was in the loop about the surgery and that's happening. I know people are also scared about this, like, okay, what does this mean? Am I doing the right thing or not? I mean, I can tell you, it's really hard for these youth to navigate through the healthcare system. So we meet lots of them who don't have primary care people, but if you're willing to learn about it, Transcare BC has lots of information that can help you understand the surgery and what's happening. The race line can give you guidance. We can give you guidance on it. But it's great to be involved. It always does kind of sadden me when I get a note that says, I just can't do this for the youth. Can you do it? But then I do it, okay? And honestly, for the top surgery stuff, all I see are smiles. Everyone is happy when they have this surgery. I don't know. It's never come back once. For all the worry about I'm doing this surgery and it's like, and it's, you know, it's gonna, is it the right decision or not? I don't know. The top surgery, it really does make the kids so much happier. They've been binding their chest for years and now they don't have to anymore. So, but there's lots of ways that you can learn more about surgery and the surgical pathway. And you're not really the decision maker. You're helping enable their referral to see a surgeon who's the person doing the surgery, right? But there is a certain degree of paperwork that needs to happen. So I often end up doing the paperwork, the like family physician referral paperwork for these kids. So I hope the what do you say question is, maybe you say, tell me more about that. Or I know nothing about what metoidioplasty is, but could you explain it to me? Because you know they've watched like 4,000 YouTube videos about it. And they could probably teach you a lot. And then the next time someone comes in, you'll know more about it. Okay, this is one of my last slides. I think it's maybe my last one. I'm not in a place to tell you who you are. That's not my role. But I interact every day with youth who are navigating the healthcare system. So these are my thoughts. Roles for GPs in care of trans youth. So number one, provide excellent primary care. Like those slides said early on, right? Youth are looking actively for care providers who will be safe, who will be caring, who will be inquisitive. I try to go to clinic every day and acknowledge all the things I don't know. I learn more from this group of teens than I do from any other population that I work with. And I try to always ask the question, when they say a word that I don't know or a term that I don't know, or they want to be on a medication that I don't know much about, but they've heard about on Reddit, I ask them about it, I learn about it, and then I know more for the next time. So providing physical health, mental health, sexual health, and supporting safety in their community are huge roles that can live in the primary care space. Second level, support gender-affirming care. Absolutely. Collaborate with Jagoda or Tara or myself, learn about it. Be a person that they can visit for the occasional. We see people from all over the province, you know, be a local home for someone to go get a check-in, do that blood pressure or physical exam, whatever. And maybe some of you leading gender-affirming care. So there are many family physicians who are stepping up in the province to actually be a wonderful home for gender-affirming care to happen and starting to care for more and more people and then understanding these pathways and really being leaders in this. And that's Transcare BC absolutely supports that idea of moving toward becoming a specialist within family practice around this. There is absolutely a tremendous need for care providers with a focus on probably everyone, you would say, but I say youth, right? And young adults, by the way. Like, I end up with all these, we finally had to start graduating people because we were just getting so many young people coming in. We had to start graduating people. We were seeing people who were in their 30s at Children's Hospital. Why? Because we couldn't find them any homes anywhere to go. And we still hold on to people on the island. We have nowhere to graduate them to. People in Fraser, often we don't have. I love having some colleagues here in Surrey that I can refer to, but I'm totally lost when it gets out to like Langley, Chilliwack, Abbotsford for the young adults when they're past foundry age. So, so if you become a home for this kind of care, let me know because I'll send you people because we have lots of young adults who are amazing who want care providers. that's where I live and work at Children's Hospital, and that's all I have for you today. But I'd be happy, I'm sure if we have a moment for questions, I'm happy to do that too.
Our first question is, how old do you have to be able to start hormones?
Okay, so there's a range of different, I'll speak to this one again, I think. There's a range of different people out there, right? So there is the youth living in a community who knew that they were trans from the like 3, and they said, Mom, I want to cut off my penis, and now they are 10, and they're starting their blockers because puberty started, and guess what? Now they're 12 or 13, and all the other kids are going through puberty. So that youth is different than someone who at age 13 puts up their hand for the first time and says, I think I might be gender diverse. So there's a bit of nuance here. I would say I don't think anyone is probably starting hormones under age 13 in the province. I think age 14 and 15 is well established as an age where youth have the capacity to be involved in that decision making. The BC courts ruled on a case where they felt a 14-year-old had the capacity to make that decision. Now, some youth may not. Someone who's, has, I don't know, a youth with fetal alcohol syndrome may not have the capacity to make that decision. A youth with Down syndrome may not have the capacity to make that decision. So you can't say one age for everyone, but I think it's pretty well established that in the teens, youth should be empowered to be involved in this decision making.
What's the wait right now to get into children's?
I think, there's different bottlenecks at different times. So we try to see people pretty quickly. The readiness piece takes a little while and takes some navigating, depending if someone has extended health or not. And so that's not a perfect system right now. I would say if someone is very time sensitive and it's a high priority, we try to help out as fast as we can or find them answers as fast as we can. But.
Thank you.
Yeah.
Can I just ask, would you do, if their parents didn't know, would you start it?
Okay, that's a great question. I should have had a slide about that. So I work in family-based care, right? This is like Children's Hospital. This is what we do. We work with families. So I like my role because I work with the teens, but I also, and the younger kids too, but I also work with the parents. So if it's an unusual situation to have someone come for care because they probably can't the barriers are so great if you have no supportive people in your life to even get to us at tertiary care. So I know those kids exist, but they're probably getting stuck along the way. For youth who present with one parent, one supportive parent, I always say, where's the other parent? And then I say, I want to talk to them.
There's no parent,
But if there's no parent,
and they're 16.
yeah, so I think you have to that's active decision making about, are you going to treat this youth? Okay, so the concept in BC, right? You can either, we do 2 forms of consent. 99.9% of the time, we use a minor consent model where the parents are involved in the decision making and where the youth are providing their assent or consent as they're able, but that's working as a group and the parents are involved in decision making. Because that applies to actually most family situations that we work with. But there are situations where you might think, does this youth have the capacity to be a mature minor? Under the Infants Act in BC, there is no age of consent. So the age of consent is deemed to have capacity to understand the information and make a specific decision at a specific time. So it's perilous because there's lots of things that might make that more complicated. I would want to know, is the youth living with, I would have some questions about it, because if the youth is living with those parents and then you're going to start them on testosterone, their body is going to change. Will they get kicked out of the home? It still has to be in their best interest. What will happen to how will they have money for food, let alone medication, if they get kicked out of the home? So you got to work through that. It takes a lot of time. We typically try to build bridges with parents. And a situation like that, I would be, of course, worried about the family situation and want to make sure we had a very safe plan. Yeah. Yeah. Lupron is the leuprolide acetate is the generic name.
Have the hormone readiness assessment? Because that's something like
Yep. Yeah. So. Yeah. Yes, that is a step that happens. There's different models in the province, so you may come across a pediatrician or a family physician who actually does the readiness planning part and prescribes the hormones themselves. We tend to work in collaboration with folks who do a readiness assessment. We've got psychologists at Children's who do it with us, or private psychologists. And there's different wait times for different people and different pay scales for different avenues. So we have social workers and we kind of try to work through that to help someone navigate it in the right way.
But do you require a HRA to be completed before Lupron's initiated, I guess is the question, or just before feminizing or masculinizing? Like, can you start the Lupron
as a
HRA
general rule, yes. There are situations where you would, in a harm reduction setting, work in collaboration to try and solve a problem. But as a general rule, we try to navigate those things together. I mean, partly because once you start something, then your motivation to go through the process of thinking through it and we're working with youth too, right? So this is a bit different than fully determined adults who are making their own decisions. It doesn't necessarily serve the whole process because we involve parents and yeah, we try to do it in a thoughtful way, but yes. Yeah?
How frequently you see gender dysphoria with other mental health problems like ADHD, maybe?
Yeah, all the time, all the time. So it's known that ADHD and autism, those circles overlap, and then gender diversity as well overlaps. So we meet many youth who are autistic and many youth who have ADHD. So
isn't it a heavy burden to treat everything at the same time, or?
Well, I mean, there's no recommendation that you should limit gender-affirming care for someone who's autistic. In the opposite. Yep. Yeah. I mean, I would tell you, I adapt so that I feel like now I treat as though everyone that I meet is neurodivergent, because like in terms of creating a calm room that is thoughtful and not too loud, and like all those things, and respecting how people might want to interact, and understanding that sitting in a clinic room for hours and hours might not be the right thing for someone. Like, we just the prevalence of neurodivergence is so high in the group of youth that we work with that, but it comes with lots of strengths, right? Youth who have learned a tremendous amount of information, who are incredibly curious and information seeking.
Is there any study about their academic development while they are going through this dysphoria?
You mean, I will just tell you from our experience, youth are often tremendously stunted who have had a very difficult period in adolescence without receiving care, for sure. And then we often see people totally flourish as they move forward from that. So we frequently work with youth who are outside of the age range for a children's hospital because they may be in their late teens, but they have been struggling socially and academically and in their family life.
We have time for one more.
Sorry.
If someone had a hormone therapy readiness assessment 2 years ago but hasn't started hormones, do they need another assessment to initiate therapy now?
I mean, it's all about what information's there and what information. So every time I meet someone, I say, okay, this is great. I have a document. You saw a psychologist, and maybe it was a week ago, but what if it was 6 months ago? And I'm curious about what's happened in that time. What has changed, or has anything material changed over that time? I think we are. my colleague up here asked a great questions hinting at this. We're constantly trying to balance a system that is providing the right amount of safety and information gathering without unnecessarily being burdensome. So I acknowledge that a youth who's already answered 1 million questions for someone, I don't replicate all of that exactly. I read the document thoughtfully and I go in and I say, this is what I've heard. Did I get it right? What pieces are wrong or what has changed? Because there's many hoops that people have to jump through for sure in accessing care.
I'll make the comment. I've once ever asked for a hormone readiness assessment. This was with somebody that had one done in the 90s. Took about a year's worth of hormones, decided they did not want to take them. And then there was a lot of personality disorder. The patient had multiple personality disorder that was diagnosed after that HRA was done. And they were coming to me after they had killed off their male self. So this is where we talked about HRA and mostly for myself and the family physician to help guide how quickly we should be titrating this therapy and whether it is still appropriate given the mental health concerns.
Thank you. Just thanks for questions and answers. I want to say thank you to you guys for staying a couple of extra minutes. Also, we appreciate the time. There is an evaluation survey on your table, QR code or paper. We ask you to please fill it out. Please take your toolkits home with you. There's some additional resources on the back table. You are welcome to take those with you. And our next session, our third and final one, where we are going to bring back our patient partners who were with us for session number 1, is going to be on June the 3rd. So mark it in your calendars, and thank you very much.